Welcome to part 2 of chapter 8, Drug Use and Addiction, as we begin addressing the topic, substance use disorders. So, as I mentioned, the DSM entitles it substance use disorder. What does that mean, a substance use disorder? More importantly, do you have it, right? So, how do you know if you have a problem? How do you know if it's disordered or deviant? Well, the DSM says that you have a pattern of using the substance that leads to clinically significant impairment or distress for at least 1 year with 2 or more symptoms. Let me say that again. And we have a slide for it, right? It's a pattern leading to significant impairment or distress for at least 1 year with 2 or more symptoms. Now, you might be saying, well, what are the symptoms? Well, here we go. So, if you got in the last year 2 of these symptoms, well, that's a red flag. Now, we're talking about substance use. Remember, there's 10 classifications. So, we'll get into the classifications and the specific drugs in a minute. But the chapter takes us through just substance use as I would say, the umbrella term, all right? So, substance use disorder symptoms, right? Taking the substance in larger amounts and for longer than intended. So, you didn't intend to drink this much, but you did. So, it's larger amounts for longer than intended. That's the first symptoms. Maybe you don't have that. Let's move to number 2. You try to cut down, unsuccessful cutting down, despite that desire. So if Monday you go, I'm going to cut down, but Friday you go, nah, that was ridiculous. I should have eaten more. Well, you can't go, no, I didn't really need to cut down. You had unsuccessful cutting down. If you decided to cut down and then you didn't, that's unsuccessful. All right, just saying. So now you got one. All right, the third one is spending time to obtain the substance or recovering from it. Well, that's hard because, spending time to use or obtain the substance. There's something, you got to go to the grocery store to get some alcohol. But you know what I really mean. You're looking. You're like making calls. You're all over the place. You are focused on spending time to obtain that at the expense of what you could be doing or should be doing. The next one is craving. You crave it. You want it. And this could be, ready for this, psychological craving or physical. So I want it, physical, right? I want it, feeling it. The next one is you have a failure to fulfill one of your major roles. What does that mean? Well, all the things we do, you don't show up for it. What are the things you do? They're different than what I do. Maybe you're a student. That's your role. You don't perform at school. You don't come to this, right? Because you have a hangover. That's it, right? That's the symptom. Or maybe you're a mother and you can't take your child to school. Or you're a parent and you pass out every night for your husband. That's not fulfilling your role. You're not fulfilling an obligation, right? Okay. Reoccurrent use despite problems, persistent problems. What are the problems? I don't know. You keep having the same problem, over and over, and it's after this thing, and you do it again, right? Maybe you fight with someone. That's a problem. Every time you drink, you fight, or every time you do this other substance, you fight. Well, again, persistent. Giving up or reducing other activities. You don't want to do the other stuff because you just want to do whatever you're doing. You at the expense of everything else. Everything's centered around that activity. Continue to use in situations that might be hazardous, right? You're driving and you're still drinking. Maybe you're sick. I have a friend that continued to drink and she has liver problems. Hello, that's one of them. All right. You continue to use despite knowing problems you've caused, right? So maybe you've already had problems like you lost your job or you got some legal trouble. And that's a problem. You've already gotten caught maybe with some pills. I don't know. But you continue to use, right? So again, don't rationalize and say these aren't problems because they are. All right. We have what's called tolerance. Tolerance is you need more of it to get the same effect. So you might have remembered this. You got to school, you might have had 1 beer, it felt good. 2 beers, you were smashed. Now, by the end of the term, you need 2 bottles. No, I'm just kidding. But you build up a tolerance. At first, you needed this, but some drugs, by their very nature, build up in your system, and you need more to get the same desired effect. Then we have withdrawal, the other of this last of the symptoms. And when you stop using that, you're going to develop symptoms. So it's a withdrawal effect. So these are the symptoms of substance use disorder. Now, if you have a cold, you know, we'd say, are you sneezing? Right? Do you have a sore throat? Do you have a cough? The more symptoms you have, you got it. The more likely you to have it, the cold. So the more of these symptoms, you got it, the more likely you are to have a substance use disorder, right? So we have 10 classifications. I don't know what your specific use is, but we've got alcohol. We've got caffeine. Caffeine, that's in the DSM. Cannabis. Sorry, wake and bakers. Now it's kind of interesting because when we get to some of them, we'll see the cultural relevance. When I teach psychopathology in grad school, I get people from different cultures that say, hey, that's a common norm. You know, I live in a culture where that's just what we do. It's social, it's not considered a drug. But some people say the same as alcohol, right? Some cultures, they drink all the time. So we have hallucinogens, inhalants, opiates, sedatives, hypnotics, stimulants, right? We'll talk about all these. Tobacco, right? And other unknown substances. So as I said, before we used to just have polysubstance abuse. If you dibbled and dabbled in a few of them, now you get the stamp on each one. Because don't forget, we have mild to severe. So you might say have a alcohol use disorder that's severe, and you might have a, I don't know, stimulant use disorder that's mild. Now again, I had a client come talk to me one time, and he was, actually his wife thought he was doing coke. Now when he came to me and they came separately, first of all, I'm a therapist. I'm not going to judge you, right? So I just state what the clinical book says. It's not about whether I think coke's good, bad, not good, great, you know. In Peru they use it, the coca bush as a means of spiritual enlightenment, right, and sustainability. But what we're here is we're not here to judge. So, you know, I had to look at the symptoms. Does he have the symptoms? Well, he did do cocaine, several times a year. Now, is that a problem? Well, potential harm. He could get in trouble. It's illegal, just in case you didn't know. He was fighting with his wife, so he might have 2 of them. But, you know, technically, he might not be diagnosed with that stamp from the DSM, even though, wait, that's bad. Coke's bad. Again, it's not about moral deficiency. We're looking at science and what the book says that states, again, whether something is a disorder, right? So even though society might say this drug's deviant, again, we have to look at the social times and the cultural restraints of that time, right? Opiates, there were opium dens. Some of you know I collect rare artifacts, right, from different cultures. So I have all kinds of paraphernalia that I found when I was in China. But, we have drugs that act on the CNS to manage pain and relieve pain. Those are opiates, right? Opiates you might get, obviously, if you have an operation. But if you just came back from an injury, they're going to give it to you. Unfortunately, opiates can build up in your system, and by the very nature of the drug itself, can lead to more use or substance use disorder. 2 or more of the 11 criteria, 2 or more of the symptoms I said within a 12-month period. So of those, you need 2 or more of the criteria that I listed, of the 11 overall criteria. Maybe you don't know what opiates is, and again, the chapter does discuss the different kinds of opiates or the different drugs within the classification. So opiates are going to include those things like fentanyl and codeine and hydrocodone and Roxy's and Demerol and Oxycontin and morphine, right? Heroin. So we can have street drugs, right? Opiates. Heroin is a street drug. It's caused a really recent epidemic because of the amount of the prescription opiates that were prescribed. And when people couldn't get their prescriptions anymore, they just went straight to the streets and got heroin, right? Because heroin is an opiate, okay? So again, we move to the second class, which are sedatives. And again, 2 or more of these, of those symptoms I mentioned, 2 or more of the 11 within a year. And so what are sedatives? Well, sedatives and hypnotics, okay, so it's the same drug. It's called sedative and hypnotics, but it's the amount you take. So a sedative will sedate you, take more, and, you know, you're done. Hypnotic, you're done. You're out. So things like, you know, people take a Xanax or Valium to relax, but as you know, they can be used to prevent real sedation, and people use them as a sleep aid. So we have Xanax and Valium, 2 or more of those symptoms of the 11, and you've got this sedative use disorder. Maybe mild, but if you have more of those symptoms, it leads to severity. Quaaludes, Librium, Ambien, right? Lunesta. These are all forms of sedative and hypnotics. The next classification, and by the way, just as we mentioned, the CNS stimulants, CNS pain relievers, these slow the central nervous system down. They slow it down. They are prescribed, as we mentioned, to reduce anxiety, but as the higher doses as a sleep aid, and then it's referred to, as I mentioned, a hypnotic. Stimulants, what do stimulants do? They stimulate you, right? They increase that central nervous system. 2 or more of those 11, and you have stimulant use disorder. Craving, remember? Saying you're not going to do it and doing more. Cocaine was big in the 1980s, yet that availability increased it to new users. It had a low stigma, you know, at that time in the 80s. It was popular. People didn't see it necessarily as deviant, sort of a status drug, right? I remember when I was in college, it was, you know, rich people had it. Rich people got coke, you know, and that was used to party, you know. Crack, as you know, another form, a stimulant, a different form of cocaine. Crack itself, certainly much more a problem because of the nature of the drug and the effects it has on you. As you take it, the level of dopamine that increases, you're much more susceptible to want it, to keep going back to it. Terms related to crack, you know. We have 8 balls, as you know. We just look at this because, certainly in sociology, we're interested in the terminology. So we have an 8 ball, as you know, is used as terminology. A cookie, which was a large quantity of crack. And then we have crumbs, which is small rock. And again, this is part of that culture of the deviant use. Amphetamines, again, are another stimulant, right? So we move from stimulants to cannabis-related disorder. Cannabis use disorder, you can have that cannabis use disorder if you have 2 or more of the 11. But then there's also, as we mentioned, within all of these, we have what you could have intoxication or withdrawal. So I mentioned the intoxication and withdrawal in this particular slide because think about it. This is the definition of cannabis intoxication. All right, behavioral or psychological changes, some impaired coordination, some euphoria. Okay, a sensation of slowed time, impaired judgment, social withdrawal, increased appetite, dry mouth. Okay, but that's a symptom of taking the substance, which gets interesting because when people take marijuana, they usually do it for a psychological or a behavioral change. It's prescribed to help you with appetite. I don't know. So that's confusing, right? Euphoria. If you look up certain strands of sativa or indica, it will list one of the effects of euphoria. So how is this intoxication if that's like saying one of the effects of alcohol intoxication is relaxation. I don't know. Yeah, euphoria can certainly move forward, but appetite, dry mouth, these are all regular symptoms. Okay, but cannabis withdrawal. So maybe you've had cannabis withdrawal. Maybe when you stop or reduce heavy or prolonged use of over at least a few months, within 1 week of that, you have irritability, nervousness, you can't sleep, decreased appetite. That's going to occur when you withdraw from that substance. So what I mean by anybody who takes marijuana for a long period of time, prolonged use over a few months, and then stops and within 1 week has some restlessness, uncomfortability, physical symptoms, that is, cannabis withdrawal. That is a term. That is the label you're going to get in the DSM. And guess what? Insurance is going to actually reimburse you. So again, some of the more we can understand withdrawal symptoms might include stomach pain, shakiness, tremors, sweating, fever, chills, or headache. And again, we can understand that as being much more severe. So again, cannabis-related disorders as one of those 10 classifications. Inhalants, huffing, maybe you've heard of that. That's certainly in different regions. People use gasoline, all types of chemicals to get a really quick high. 2 or more of the 11 in a 12-month period, and you have mild use, inhalant mild use disorder. That's using a volant solvent, like I said, aerosol, gas, nitrates, right? Bags or balloons, canisters, gasoline, nitrous oxide. Again, people certainly get addicted to that. And as I said, huffing can be extremely dangerous. The brown paper bag, huff over the course of several hours, and certainly increasing the effects of the drug and damage of the drug, right? Caffeine-related disorder. Now we're talking, right? Again, 2 or more of the symptoms. But what about caffeine and intoxication and withdrawal, right? Added to. So here we go, intoxication. After 250 milligrams, that's a typically high consumption of caffeine. 5 or the more must be present. So after 250 milligrams of caffeine, you have 5 of these. Restlessness, nervousness, excitement, insomnia, flushed face, stomach problems, heart twitching, rambling flow of thoughts, periods of inexhaustibility, psychomotor agitation. That's caffeine intoxication. Now, withdrawal, prolonged daily use. So you use it for a while, and then after you stop, you have 3 of these symptoms. Now, most people do have these symptoms when they stop using caffeine. So you can actually have the label caffeine withdrawal. Ready? Headache. I don't have coffee one day, I get a little headache. Fatigue, drowsiness, depressed mood, irritability, difficulty concentrating maybe, flu-like symptoms. Okay, nausea and vomiting, muscle pains. But again, these are all part of taking that caffeine-related disorder. So you can get that diagnosis, right? All right, gambling, new one, right? That's called a process. It's not a chemical. So it's addiction or use disorder, but it's called a process-related use disorder, process. You're doing something. It's not a drug, process. So shopping, gambling, sex, all of these. And if you take the psychological issues of addiction and compulsive behavior course, we speak much more of this. But a recurrent problem of gambling behavior leading to clinically significant distress or apparent, seen by 4 of the following in 12 months. You need to gamble, right? You got to gamble with increasing amounts of money in order to achieve that same excitement. So again, that tolerance, right? Restless and irritable when you can't make the bet, or you're tempted to cut down, not do it, not bet on that sport, not watch it. Or you've made repeated attempts to control or cut back, unsuccessful, right? To stop. And then you're preoccupied with it. You can't stop thinking about it. You're planning your gambling, past gambling thoughts, the next venture. When am I going to get money? You know, how am I going to get this next? How am I going to get money? So we've just talked about, you know, many types of use disorders, the different classifications, and I introduced the process addictions with gambling. This is part 2, and we'll move into theories of addiction in part 3. Thanks, and have a great day.